Good morning. I trust everyone can hear me.
No.
Let's see. Well, I'll project. I'm sure you'll be able to hear me soon once the technology kicks in. There we go. Good morning, everyone. Thank you for coming today. My name is Michael Kugelman. I'm the Senior Associate for South Asia with the Wilson Center's Asia program. The Labor Day week is a notoriously busy week in Washington, so we're very grateful that you've set aside the next 90 minutes to spend with us. I imagine that what I'm about to say will not be news to anyone in this room, but I will say it anyway. Pakistan is a nation that faces a number of challenges that go well beyond issues of terrorism and militancy. It faces a number of challenges bearing on human development, ranging from education to energy and water security, all topics, incidentally, that the Wilson Center has covered in its work in recent years. Another major challenge in the country is health. Pakistan is a country with a strong prevalence of diseases such as tuberculosis and polio, as well as high rates of infant mortality and children's malnutrition, among other things. These challenges present economic and national security implications. Can Pakistan's large young population, its youth bulge, be properly educated and trained for the labor economy if it suffers from such health-related challenges? And if a lack of access to health care and to other services constrains the ability of young people to receive proper education and training, could extremist groups capitalize or try to capitalize and try to draw young people into their orbit? So health is a very real concern in Pakistan, and here at the Wilson Center we apply a broad lens to the country that enables us to look at the various types of issues that in Pakistan that often don't get as much attention as they should in this town. So today we're very honored to be hosting Her Excellency Sarah Afzal Tarar, Pakistan's Minister of National Health Services, Regulations and Coordination. She will speak on Pakistan's health situation and how the Pakistani government is addressing it. And she's joined by a panel of experts who will also be weighing in on this critical topic. They include Zulfikar Bhutta, Richard Sinkata, and Dan Grant. We'll actually first hear from Dr. Bhutta, who is actually joining us remotely, as you can probably tell, from Karachi. And his presentation will consist of a brief video on maternal and child health. Dr. Bhutta is the Hussain Lalji Diraj Professor and Founding Chair of the Division of Women and Child Health at Aga Khan University in Karachi, and he also holds several, pardon me, I'm hearing myself twice at least. He holds several joint professorships, one at Tufts, one at Boston University. After him, we will hear from Rich Sinkata. He is a Wilson Center Global Fellow and the demographer in residence at the Stimson Center, and his research is focused on demographic transitions and its relationships to political change. We'll then hear from Minister Tarar. She is, as I said, Minister of National Health Services, Regulations and Coordination. She's been in that position since June 2013. Before her political career, she was a teacher, and she taught at a number of public and private schools. Fourth and finally this morning, we'll be hearing from Dan Grant, who is the Deputy Assistant to the Administrator in the Office of Afghanistan and Pakistan Affairs at USAID, a very long drive away from here. He oversees a portfolio that includes, among other things, public health. So with that, I am going to yield to I'm going to yield to Dr. Bhutta's presentation, which, since it doesn't include us speaking right here, the echo will not be an issue, at least for now, and hopefully that will be resolved momentarily. So let's roll the video of Dr. Bhutta's.
So, ladies and gentlemen, Honorable Minister Tarar, I'm delighted to be able to speak to you today, and I apologize for the fact that because of commitments in Pakistan, I could not be with you in Washington, D.C. this morning. I've been given the charge to speak to you to try and convince you about the importance of maternal and child health in the context of Pakistan, and why is it important for our national security in the long term. in the context of human development and action. This material that I'm going to share with you builds on our previous analysis over the last several years on trying to put the objective evidence of maternal child health and survival in Pakistan, both in terms of current challenges and also the opportunities that exist for improving the situation. If you look at maternal survival, Pakistan has made progress. And although we started off with perhaps maternal mortality rates that were fairly high, in excess of 500 per 100,000 births, today as we speak, from the best available information, including a large survey that was done a few years ago, we are down to where we believe our consensus figures are below 300 per 100,000 births. But these may vary in different parts of the country, and I will illustrate that a little later. In the context of child survival, the situation is perhaps also comparable, but only partially. So if you look at overall under 5 mortality, Pakistan has been able to reduce under 5 mortality, but still is way behind our Millennium Development Goal 4 targets of getting to around 41 per 1,000 live births. In contrast, as you can see, the slope for reduction in newborn mortality has not been as steep, and progress in that has been much more limited. To look at it more specifically from available national surveys, although we have reduced child mortality from 1990 by about 26%, our newborn mortality rates for this comparable period haven't changed, and that remains a big enigma in terms of why there has been so little change in reduction in this particular area of child survival. When you look at it a lot more closely, we find that by persistent efforts and by the improvement in our primary care programs, there have been gains in interventions and their coverage over a period of time. So if you look at antenatal care, if you look at maternal tetanus immunization or stillbirth attendance rates, these have gone up on an average from about 20% in the early 90s to what we believe is around 60–70% coverage overall. The same is also true for many of the important child health and newborn health interventions, including facility births, and including also access to things like cesarean section rates that overall at a national level now lie close to around 10%. There are some key interventions, however, where we haven't made progress or progress has plateaued, and those relate to things like postnatal visits and also importantly exclusive breastfeeding rates, which have stagnated at around 23–30% over the last many years. So there are a number of reasons why perhaps we have not been able to achieve the reduction in newborn mortality that we would have aspired to. One of those, not measured and captured on this particular slide, relates to what has been happening to population growth in Pakistan. So if you look at the clustering of these deaths, a lot of these deaths for mothers and newborns are around the day of birth, the very first day of life. And in addition to maternal and newborn deaths, we have close to around 100,000 intrapartum stillbirths, which are an extension of newborn deaths that occur also around this time period. Now, why I mentioned the whole issue of coverage rates of key interventions is because there is disparity in terms of where people are delivering. So this slide captures the district-specific rates of people who are delivering in a health facility in various parts of Pakistan. And as you can very clearly see here, although there are provinces and regions where a reasonable proportion of people, around 40–50%, still not optimal, are delivering in facilities. Look at Balochistan and parts of Khyber Pakhtunkhwa, where less than a third of the population delivers in health facilities. I mentioned population growth rates, and one of the important things to remember that in comparing 1990 with data today, and as you see for 2013, actually we have increased our total birth cohort from about 3.9 million annually to 4.8 million. So we essentially have 1 million extra babies being born every day because fertility rate reductions haven't kept pace with what is required optimally to stabilize the population and to reduce its rampant growth. And that probably is also one of the other important areas that influence the slowness in reduction of newborn mortality. You can see this also from the proportion of populations in various districts who have unmet needs for family planning. So commensurate with what I told you in terms of the disparities around skilled birth attendants and facility births, you can see very clearly that we have many Pakistans. We have Punjab, where currently a large proportion of the population has its family planning needs met. And then we have the South. We have Balochistan, where many people have no access. And we have Sindh, where the performance of the program around family planning access and coverage has been very variable. So let me move on, and beyond the newborn period and maternal care, a big issue in Pakistan is that disorders like diarrhea and pneumonia still kill around 120,000 children every year. And these are disorders that we have principally eliminated in many parts of the world as major causes of child mortality, even within our region. So if you look at the data for Pakistan, following the neonatal period, around 20% of all deaths in children relate to these disorders, which we should not have in our population, killing children the way they do. And there are several reasons for this, which I don't have time to go into today, including some of the social determinants around environment, around water sanitation and hygiene. But if you look at clear issues around care seeking and treatment provision, a large proportion of our population, and you will by now recognize these geographies and districts in the northwest and also Balochistan provinces, where a very low proportion of the population have access to care for childhood illnesses like diarrhea and pneumonia. And you see this in this particular slide for care seeking for diarrhea, and you will see this also in relation to care seeking for pneumonia in the same provinces and the same districts as being a source of huge disparity. And when you come to pneumonia, you'll also begin to see this happening for southern Punjab and parts of Sindh. So overall, over a period of time, from 1990 to the last time when we evaluated this at a national level, although coverage with antibiotics has improved, care seeking around many of these childhood illnesses has remained stagnant around 2/3, indicating the need and the opportunity for greater societal and civic society engagement. I also wanted to talk about some of the underlying determinants and to principally underscore the point that a big issue in Pakistan also relates to maternal and child nutrition. And these are quite closely interlinked, not just at a given point in time, but across generations. What do I mean by this? If you look at the data for child malnutrition, reflected by stunting, underweight, and wasting, over the last 60 years or so, Pakistan has made very little progress, unfortunately, in eliminating and reducing childhood stunting. And these rates overall at a national average are around 40%. But if you look at their distribution, we find that there are huge disparities. And all of a sudden, when you look at stunting as a measure, we begin to see parts of the population that would have hitherto in previous slides that I've shown you looked better, not look as rosy as they were. So you take southern Punjab now, and you have stunting rates which are fairly high as parts of Sindh. And you again have the whole area of the Northwest, federal tribal areas, KP, and the Northern Territories emerging as principal hotspots of child stunting. And there's a very close correlation with maternal undernutrition. So if I was to superimpose on this slide, a slide of maternal wasting as a measure, you would see that there is pretty close homology and that these are the very districts where women and children are malnourished together. In our recent analysis, when we looked at what determines stunting in Pakistan, these we just published a few months ago, you find that stunting in children, being of a short height, is related not only to maternal wasting like body mass index or poverty, but it's also related to how tall the mother is. And that immediately relates to the intergenerational effect of this, because if you're short as a girl and you're short as an adolescent and you're short as a young mother, then you will be at much higher risk of delivering a small baby who will remain short. So this is the reason why we need to invest in it over time. This particular slide is a rare slide because very few countries actually measure the rates of malnutrition in their young girls. And these are recent analyses that we have done, which indicates that in Pakistan, close to around 1/5 of all girls that fall in the adolescent age group of 15 to 19 are stunted. Important points for us to underscore in moving forward. So I want to move forward and also cover one big issue around inequities in access and coverage that I've illustrated in some way around the geospatial maps that I've shown you. And it's important to also underscore that these are just some of the few measures that we have. So if you look at equity around the range of interventions that we have from pre-pregnancy, pregnancy, childbirth, and beyond, this slide shows you by these black dots the differences between various districts. So even the median values, the average values, do not give you the same story around the dispersion and the variation between districts in terms of coverage. And that's one of the big challenges that we have as public sector, program policymakers, and implementers around how we need to bridge this equity gap. This gap is also reflected with other measures that we have typically for equity, such as between various poverty quintiles. This is the way that we see for various interventions the differences between the rich and the poor. Now, this is good for an academic exercise. The problem with these measures is that they are of very little policy relevance. The Honorable Minister who is sitting on the stage at this point in time cannot potentially readily recognize where these poorest quintiles are living in a given population because they are not readily apparent. So recently, we looked at where the distribution of the two poorest quintiles was in Pakistan, and no big surprise, they are generally in the populations of southern Punjab, and parts of Sindh, and parts of Balochistan and KP, which we believe also to have the highest disparities in terms of access and care. I want to move on to solutions. And one of the biggest solutions in Pakistan that we have focused on is getting vaccines to our children. And here the government has been trying very hard, and it really is important for us to underscore the importance of this, not just for child health and survival, but also for eradication of diseases like polio. Let me make this case through an illustration of how much progress Pakistan has made in terms of getting access to major vaccines for its children over time. So if you could look at rates of coverage of fully immunized children, we've doubled that over the last several decades. And while this may still not be at the rate and level that we want, around 80–90%, it is progress nevertheless. But it's unequal progress. So if you look at the distribution of immunization coverage in various districts, whether it is for changes in fully immunized children, there are parts of the countries that have been left behind. And much of the change over time, the doubling has been restricted to parts of Punjab and parts of Sindh and KP that you see illustrated here. There are also a very important policy imperative around linking routine immunization to polio eradication. So if you look at the current distribution of children who have never been immunized as just one sad measure, and they may not be huge, they may be 20, 30, 40% of various populations. And if I was to superimpose on this map the distribution of polio cases in Pakistan, and these are data from last year, but it doesn't take a rocket scientist to work out that these are the very areas where fully immunization coverage is at its lowest. So there's a very close link between what we are trying to achieve for both global security and polio eradication in Pakistan and what we need to do to invest in the health and immunization of our children. So let me try and conclude by illustrating what can be done. And a lot can be done in terms of promoting health, but it will require concerted efforts and it will require resources, ladies and gentlemen, and support to the government of Pakistan in making health, nutrition, and addressing some of the social determinants of health a priority in our national planning. So the first point to take home is that these high rates of morbidity and undernutrition in Pakistan also illustrate huge missed opportunities for impacting child development, education, and economic development. And this is a vicious cycle because high rates of child mortality are also an impediment to achieving our gains in population level fertility control and also in promoting family planning in the very populations where we want this to be a major intervention. This is something that we can do. This vicious cycle can be interrupted. And it can be interrupted not just for addressing things in the short term. This is an intergenerational cycle of ill health, stunting, and gender differentials that Pakistan can invest in and should do over the next several decades. If you look at The feasibility of doing this, I think the grounds are very ripe. Pakistan has successfully scaled up some of the most ambitious programs of community health workers. Our Lady Health Workers program that the Honorable Minister will potentially talk about, the poverty alleviation programs, the income support program that we have that have huge opportunities for linking health and nutrition to such initiatives. Medium-sized pilot projects in various districts of Pakistan have demonstrated the potential for change and rapid gains. These models we now need to take to scale. And all of this requires resources, requires money. And we need increased investments, both domestic and also from our friends and donors, for investing in primary care and targeting marginalized populations in urban and rural settings. With the challenge that is emerging with the Sustainable Development Goals, Pakistan is well placed to accelerate its interventions to reduce maternal and newborn mortality, and we can potentially eliminate diarrhea and pneumonia deaths from Pakistan within the next decade if we put our mind to it. But it will require addressing inequities. It will require addressing disparities and reaching to marginalized populations through our existing and potentially future social safety nets. The new 10 points agenda that we have helped the government of Pakistan take forward as recently as in May this year, and is now being costed in various provinces, is a phenomenal step in the direction, in the post-devolution scenario, of translating some of this advocacy into action and to walking the talk of eliminating preventable maternal and child deaths in Pakistan within our lifetime. Thank you very much for your attention.
Well, thank you very much to Dr. Bhutta for that rich, very broad overview of the issue. While Rich gets set up to go on his presentation, two things I forgot to mention. First of all, I wanted to thank our event co-sponsor, actually two of them, the Environmental Change and Security Program and also the Wilson Center's Maternal Health Initiative. Really appreciate your cooperation. Secondly, this event is being live streamed, webcasted, and those of you here or watching elsewhere, feel free to live tweet. We encourage you to do that using the hashtag Pakistan Health. The wireless password is on both sides of the walls here. So now go to Dr. Sinkota.
Thank you, Michael, and I'd like to welcome Minister Tarar to Washington and wish her success in addressing Pakistan's challenging health problems. I thought I was going to be the first speaker, and when I spoke to Dr. Bhutta, I told him that if I was after him, after seeing his video, I would call in sick. So here I am after him, but it's not going to work. It's just an amazing presentation. I think not only of PDHS, Demographic and Health Survey data, but also of DHS. And I've never seen anything quite like that with DHS data. And there's been some wonderful presentations. It's really a work of art and great messaging. My task is to make a little sense out of the title of this event. It's Why Health is Vital to National Security and Development in 4 slides. So I'll begin by noting that this is not the way that health sector development is typically addressed in Washington or at the Wilson Center. And health reforms are typically discussed in terms of individual rights and the state's responsibility. Fine, but I like this title, and it's a political demographer's title. I'm a political demographer, and it suggests that someone is going to answer the question, what's in it for the state? Why invest more in health and family planning? What's in it for Pakistan in this case? So I'll start. How do I start this thing with? Oh, okay. Well, oh, I see. New setup here. These questions were supposed to be at the beginning, and I think you've heard a little bit about these from Dr. Bhutta, but I'll just go through the points, and they're the major points, and the first two Dr. Bhutta actually addressed. The PDHS data from 2012 and 2013 shows that Pakistan is making progress in measures of disease incidence, mortality, and fertility, but it also tells us that progress is very slow. And it's important because this is on the doorstep of some sweeping administrative changes that are going on in Pakistan as we speak, the devolution of health services. The 18th Amendment of Pakistan's constitution mandates the transfer of services from the central government to the provinces. And the next round of demographic and health surveys will tell us something about how well this worked. Was it fiscally and administratively possible? Did they pull it off? And I'm sure Minister Tarar is neck deep in that issue. Secondly, Pakistan can do better. Pakistan's healthcare system employs a dedicated cadre of trained health workers and health professionals. It has for decades, but something is amiss. Countries that place far behind Pakistan in health measures in the 1990s have passed it by. Sure, Pakistan's geography, its ethnic diversity, its domestic conflict are factors, but as a portion of GDP, Pakistan's annual healthcare spending is very low on the list. And I was just checking the World Bank's list. It puts it about number 6 from the bottom. So according to the World Bank, healthcare spending is about 1% of GDP, and by my calculation, that's less than $20 per person. Not much. Now, spending promises to become even a bigger issue because population continues to grow. Pakistan is at 190 million people. Right now, it's growing at 2% per year. With population growth, we can expect the demand for health services to grow, as will demand for fresh water and energy, which are vital for health services, for public health in general. And thirdly, what I'm going to talk, which is my issue, is I'm going to talk about, make the political demography point. I'll argue that Pakistan's current age structure challenges state capacity. It erodes legitimacy, and it risks chronic political instability, and it's my job to actually show you what political demographers, why political demographers come to that conclusion. Now, this is Pakistan's current age structure according to the UN Population Division's latest estimates in 2015. To read these, the graphic is actually two bar graphs turned on their sides, males on the left, females on the right. Each bar represents a 5-year age group. All the bars together equal 100% of the population. It's on a proportional basis. Infants and toddlers are on the bottom, 0 to 4, and then 5 to 9-year-olds, 10 to 14, et cetera, until you get to the top with people over 100 years old. Now, it isn't difficult to do political demography. It's an easy thing. You just have to, you can read it right off one of these age structures, age profiles. And the first thing that you notice is that there's a bulge at the bottom. Pakistan's youngest cohorts continue to grow, and those larger cohorts of children will need more and better health care, better nutrition, more classrooms, more teachers. Meanwhile, the cohort of women of reproductive age, particularly peak reproductive age, are growing, and Pakistan will need more and better reproductive health services. And finally, young adults will need are growing as well. There's a bulge in the young adult population, and those young adults will need training and jobs in an intensely competitive environment. Meanwhile, the formal job market is certainly not the only competitor for their hearts and minds and energies. They are young adults, they're idealistic, they want to see change, and they're willing to take risks to do it. Our declines in in population in Pakistan's fertility possible? Well, they certainly are. In the late 1970s and 80s, this entire map, if I had drawn the age structures of all the countries on this map, you would see pyramidal distributions, youthful distributions across the entire region. That is certainly not the case today. If we do see youthful distributions, one is Pakistan, even more young, Afghanistan, still Nepal, but Nepal's fertility has declined substantially over the last 15 years. And that age structure will be changing rapidly. You can already see some of the changes going on at the bottom of that distribution. So today, South Asia is arguably the most diverse region demographically in the world. It ranges from a few youthful countries, a handful, to countries along the rim that are intermediate in their distribution. They have small, relatively small proportions of young people and a bulge in their working age population, an ideal place for economic growth and advancement. So what does this mean strategically? Here I have a graph which a lot of you have already seen. But what I've done is try to situate Pakistan in that graph. Along the bottom of the graph is people who are seniors, 65 years and older. Along the vertical axis are young people, 29 and younger. And all the nearly 200 countries of the world are situated on that graph in terms of their age structure. So up in the left-hand corner are very youthful populations, and as we move down that arc, we come to the most mature population, Japan. What all does this mean to political demographers? Well, to put it very, very simply, 80% of all civil conflicts begin in that upper quadrant. And that's been the case since the data were available in the 1970s. About 15 to 20% of those of countries in that quadrant are liberal democracies. That means they're assessed as free in Freedom House's annual survey, but they're very unstable liberal democracies. They may have reached free, but few of them will make it, will hold that status for 10 years. In the next quadrant, we have intermediate populations, and those populations experience much less civil conflict. Few conflicts actually begin in that quadrant. About 50% of those countries that you see in that quadrant are liberal democracies. And they're stable liberal democracies. They retain it for as much and more than two decades. And finally, the mature age group, which where about 80% of all where about 80% of all countries are liberal democracies and very stable. Whereas Pakistan, well, it's in that the most youthful group, and it probably will be there, according to the UN Population Division, for another at least 15 years if it holds to the median projection. In my final slide, I'd like to go back to the Pakistan Demographic and Health Survey and take a look at how Pakistan's provinces and territories line up in terms of fertility. In fact, Pakistan's fertility rate is 3.8 in the last survey, down from 4.1 in the 2006 to 7 demographic and health surveys. And amazingly, most of the provinces and territories sampled are around that average. There isn't great disparity. Of course, the Islamabad capital territory is somewhat lower at three children per woman. And when you compare this to countries in the region and outside, but if you can take a look, you can see what has occurred over the last 25 to 30 years. Bangladesh slightly at 2.3 now, in the last survey. Nepal, 2.6. Sri Lanka, about 2.1 children per woman. India, about 2.5, but that hides a lot of diversity in India. It's not the same across the country. It's amazing diversity, actually. About 1.7 in Iran. Indonesia, about 2.6 children per woman, 2.6 or 2.7. And Afghanistan, I think, a somewhat optimistic UN estimate of about of under 5. Let's say it's under 5. That's quite amazing. And then I just sort of reached outside the region to a sub-Saharan African country, which has a recent DHS, and Kenya reports a 3.9 fertility rate, 3.9 children per woman. But there is, again, that's close to Pakistan, but like most countries in equatorial belt of sub-Saharan Africa, fertility decline there has been very slow, very uncertain. There's even been setbacks, and Pakistan has not had that. And it's hard to know what Kenya's fertility will look like in the next DHS, as it is difficult to know what will happen in the next DHS in Pakistan as well. But I'm assured by my Pakistani colleagues that there are hopeful signs. I think Minister Tarar is one of them. And I'll close by saying that, unfortunately, and perhaps tragically for children and women, Pakistan's health and fertility outcomes have not yet met their expectations. With investment and political attention, they certainly could. Thank you.
Well, thank you, Rich, and I'm glad that you didn't call in sick today. Yeah, appreciate that. Another interesting presentation. I'll now invite the minister to offer some remarks.
I can talk from here.
Yes, yeah. It should be on. It's on.
It's on. Okay. Bismillahir Rahmanir Rahim. Ladies and gentlemen, Pakistan recognizes the investment in health sector is of utmost importance in order to achieve the targets we have set for coming years. We would like to ensure that our population is healthy and has equitable access to health. The relation of health with economic growth and security environment is very clear, and in order to achieve optimal growth, emphasis on improving social sector indicator is a must. Inadequate resources for social services and the fact that over half of all new poors added to the pool every year are resulting for catastrophic health-related expenditures, thus laying a fertile ground for extremist groups to embed themselves throughout society. It has been recognized in the government's 10-year development strategy Vision 2025 that current demographic trends pose real threats to Pakistan's future, including high population growth rates, exert negative pressure on economic growth, as investment funds have to be concentrated in meeting the needs of the growing population, including education, health, housing, police, and other infrastructure, rather than productivity growth. The potential demographic dividend cannot be realized unless there is adequate investment in human development, especially education, training, and health. The growing population in Pakistan poses a significant threat to food security, Pakistan development, and social indicators and stability. With almost 50% of women and children being malnourished, these nutritional inadequacies hinder the development of the intellectual faculties of school-going children and young adults cognizant to such diets, and could thus perpetuate intergenerational inequalities of opportunities and income. Given the prospect of climate change and depleting water resources, this will constitute one of the major challenges faced by the countries. Total health expenditure in Pakistan is estimated $5.4 billion US per year, of which 36% is funded by public sector Approximately 62% of the health expenditures are funded through private sector, out of which 88% is out-of-pocket expenditure by households. Currently, development partners, donors, organizations over only 2% of the total health expenditure. There is a continued need for increased donor assistance through the economic transition in health. When GDP per capita is over 1,400 and total health expenditure per capita reach $70 per capita. As evidenced globally, even when these thresholds are met, there is continued need for donors' assistance to ensure adequate funding for the best value of money, with prioritizing primary health care and prevention instead of more attractive infrastructure and tertiary health care. With the 18th Constitutional Amendment devolving health to the provincial government, the federal government as the main interlocutor with major development partners prioritize issues and donor assistance requests to subject which are squarely within the federal government's mandate. And in addition, immediate concern with security and short-term drivers of economic growth currently take precedence despite the opportunity cost of non-addressing the more insidious threats to long-term security and economic development. Despite all adversities, Pakistan has taken tangible steps to ensure improvement of health in the country, both in terms of enhancing financial resources as well as developing robust policy environment. Since 2012, provincial governments increased health allocation to 7 to 8% of provincial budget, at par with the regional average. Although inflation and growth in population has eroded corresponding increase and impact, population programs have allocated progressively increasing resources for security, family planning commodities in their own budget to the tune of approximately $60 million over the next 5 years, showing a true commitment for this vital area. The recently launched Prime Minister Health Insurance Program is a flagship initiative to support the poorest through catastrophic health expenditure, and federal government has allocated $90 million this year from its own resources. The provincial governments have allocated similar amount in their budgets. The program is a clear indication of the present government to social sector development in Pakistan. The Prime Minister of Pakistan, noting slow progress in maternal and child health agenda and nutrition, directed national leadership to develop a comprehensive action plan to address challenges. A 10-point priority agenda has been developed by the federal and provincial governments in consultation with the development partners, which includes improving access and quality for primary care services for MNCH in rural districts and urban slums through revitalization and refocusing scope of LHW program, improving quality of care through linkage between medical colleges with district health system, engaging private and not-for-profit sector in the provision of priority services, addressing staffing gaps in rural districts, and availability of essential supplies. Respectful maternity care is an idea where we would like to invest further. Overcoming financial barrier to care through targeted conditional cash transfers, vouchers and health insurance schemes. Increasing funding and allocation for MNCH over the next decade. Improving family planning through synergies between population and health department. Developing commodity security strategy. Mobilizing religious and traditional leaders. And focusing on culturally sensitive reproductive health education among adolescents and ensuring positive development assets concept for younger population. Another areas which we are focusing on are ensuring of multi-sectoral nutritional strategies with a focus on enforcement of law such as breastfeeding protection laws and food fortification. Addressing social determinants of health through integration of health and development message, and linking MNCH to education, prevention of child marriage, and gender empowerment. Strengthening mayors and district level action by strengthening the district health information system, developing link between existing information system and a national health information system to track core indicators, increasing national accountability and oversight by establishing a national oversight body linked to respective provincial structures and a high-level interministerial forum for health and population and interagency coordination forum at the national level, generating political will to support reproductive health, MNCH, and nutrition as a priority within the Sustainable Development Goals. Pakistan planned to meet the National Vision 2025 commitment of increasing allocation to health at 3% of GDP in next decade. However, this should also include a similar commitment for partners, including the US government, to enhance the development assistance for social sector, in particular health sector, for us to achieve the desired impact. Domestically, we are committed to developing realistic plans for phased increase in health spending and exploring innovative ways of generating domestic finances, such as imposition of tax on luxury items, nutrition levies on soft drinks and tobacco products. The federal government is also creating incentive matching fund programs to augment a provincial budget to address primary health priorities, similar to the nascent Prime Minister's insurance scheme to address catastrophic health costs, which is co-funded by the federal and provincial government. The battle against polio is another avenue which clearly shows government pledge to health and its international responsibility. Last year saw enhanced ownership and political commitment at all levels of the government. The formation of the Prime Minister's focus group on polio eradication reflects strong political commitment of the highest leadership. Based on the decisions of the Prime Minister, focus group on Cabinet Committee on Routine Immunization was formed to include Ministry of Defence. These steps have had a major impact in coordinating security efforts with the provinces and improving the overall security planning of the program. The provinces recently, the number of the cases had dropped to less than 80% of the as compared to last year. However, we are still cognizant of the ongoing transmission and have prepared a robust plan to be implemented in next 6 months, focusing on continuously missed children as well as quality of campaign. In last 3 years, Pakistan contributed the entire cost through a loan arrangement. In the coming period of 2016 and 18, Pakistan will continue to fund the polio program, and we are negotiating a balanced mix of domestic and international resources to cover the cost of $337 million for this period. Ladies and gentlemen, we keep on reminding ourselves that we need to reach every mother, newborn and child to reduce inequities and harness the power of partners, families and communities. Let me emphasize in the end that our government is fully aware of the importance of investing in health and social sector, and we would like to explore along with partners like US government and others to mobilize more resources for our shared vision and bring health sector to play its due role in economic development and global security. Thank you very much. Pakistan Zindabad.
Well, thank you very much, Minister Tarar, for that very rich and also very hopeful presentation, which is nice to hear. Well, before we open it up to questions, I just wanted to give an opportunity to Dan Grant to weigh in and perhaps say some words about USAID's work and its support to the minister.
Certainly. Let me go to the podium, if I may. Sure. I've been asked to keep my remarks to under 90 minutes. No? Oh, okay. A lot of what's going to be discussed on my end is going to echo what my colleagues up here have said as well. This is largely, though, from USAID's perspective. But before I get started, I wanted to thank the Minister for taking time out of her busy schedule to be here today to discuss these series of important issues, and also the Wilson Center for allowing us this forum to talk about them. I am here as the representative of USAID. I'm the Deputy Assistant to the Administrator in the Office of Afghanistan and Pakistan Affairs, with Pakistan being my portfolio. Part of the reason that USAID has a Pakistan health program is to act on our country's shared bond of humanity to help those that we can, but it's not the only reason. With almost 200 million people, Pakistan is the 6th most populous country on the planet and has the highest population growth rate in all of Asia, as been demonstrated in some of the earlier material. And now, if Pakistan's youth are healthy, educated, and able to enter the workforce and society as proud, productive members of it, it would absolutely produce a demographic dividend, as the minister spoke of, and be a boon to both Pakistan's and the region's economy. Now, this is why USAID partners with the government of Pakistan in 5 key areas: energy, economic growth, community resilience, education, and public health, to help the people of Pakistan realize their potential and help strengthen Pakistan against extremist interests both at home and abroad. Now, on health, the statistics are not currently in Pakistan's favor, and they do start early, as has been shown. The unmet need for family planning contributes to Pakistan having one of the highest rates of infant mortality on the world, resulting in the country's distinction as one of 5 countries that account for half of all under 5 deaths globally. Now, of those children that survive past their 5th birthday, 44% will suffer the consequences of malnutrition, which leaves almost half the future generation with impaired cognition or physical stature. Now, the good news is that Pakistan and USAID have been working in partnership with one another in order to help address this concern. Solving this demographic challenge starts with strong family planning. USAID has successfully partnered with the government of Pakistan to mobilize resources to phase out USAID's donations that covered 70% of all Pakistan's contraceptives from 2009 to 2014. For an example, leveraging the Sindh Department of Health's extensive network to provide family planning, the number of women served has increased by more than 5 times historical averages in areas that USAID is focused. It also continues a strong prenatal care and birthing practice regimen that has been introduced. Since 2013, USAID completed a state-of-the-art obstetrics and gynecological facility at Jinnah Postgraduate Medical Center in Karachi, and it provides training for over 1,300 healthcare professionals and care for over 140,000 low-income women annually. It also entails a lifetime of better healthcare for all. In the last 5 years, USAID has trained over 29,000 healthcare workers who have served over 3.5 million community members throughout the country. We are also continuing to introduce best practices and innovations that will be institutionalized within provincial and national practices for accelerated progress in public health. For example, chlorhexidine. Now, this is getting somewhat technical, but it is vitally important. It's an antiseptic gel that is put on the newly cut umbilical cord to prevent sepsis infection on infants. And this has been piloted in Sindh, which reduces newborn deaths up to 1/3, 32%, at the cost of simply $1 per child. Now, this has been included in national policy across Pakistan and is being scaled up across the country in conjunction with USAID's technical assistance and funding from both the government and other international partners. Now, USAID and other donors can help with the latest advances in public health and epidemiology, and technology can also help Pakistan leapfrog its healthcare concerns and systems into the 21st century to join the rest of the community of nations. However, it will take real will and a commitment from the government of Pakistan to heed the advice of its own experts, like the Minister of Health here, to make sure that the people on this panel, the government of Pakistan and its people, can appropriately resource and implement the proven, well-worn solutions discussed here today. This is not an abstraction. People's lives hang in the balance. And it is through the good work of the people here and the minister that we've seen real progress. And so I'm grateful we've had the chance to get together and talk about this, and we'll answer your questions. But thank you very much for your time.
Well, thank you very much, Dan, and thank you to all of 4 of the presentations, which I think really complemented each other well. We're going to go to the audience in just a moment, but in order to kick off some discussion, I thought I'd pose a few questions to the panel. And unless I'm mistaken, I believe Dr. Bhutta will be joining us and should be on hand. So can you hear us, Dr. Bhutta? Well, I believe he'll be joining.
Yes, I can.
Excellent,
Yes,
thank
I
you, and we
can.
can hear you. Okay, so all 4 of the panelists will be on hand to answer your questions. My questions are as follows. The first one, I'm going to go back to this issue of the 18th Amendment and devolution. This is a very important topic. I mean, as many of you know, in 2010, Pakistan passed the 18th Amendment, which essentially transferred a lot of federal responsibilities and resources to the province, and it entailed the elimination of a number of federal ministries, including the Federal Ministry of Health. So one question is if this new system, which has been in place for 5 years or so now, if it's working for health, and do adjustments need to be made? So that would be the first question. Second question is if anyone would like to comment on success stories in the health sector these days. Polio immunization certainly stands out as an example, but are there others that deserve to be highlighted and that can perhaps be replicated elsewhere? And on that note, are there useful lessons from other countries' health reforms, policies, projects that could be applicable or useful to the case of Pakistan? And finally, a different kind of question, but I think one that's worth mentioning in this town, is the issue of aid programs. I think that, to be realistic, we can assume that future aid programs in Pakistan may suffer cuts. So looking forward, looking ahead, what are the most cost-effective yet nonetheless impactful ways of assisting Pakistan's health sector? So 3 questions. First, the issue of the 18th Amendment. Secondly, success stories and or case studies, examples from other countries to highlight. And finally, the issue of aid programs. So who would like to start?
Thank you, Michael. Actually, I think we are facing the same problems and challenges in 18th Amendment like all other countries. 18th Constitutional Amendment is a challenge as well as opportunity. So if we look at the performance of the provinces, it is improved because they are the one who are implementing, and we are not in service delivery. But at the same time, there are certain things which we are given to them in haste without building the capacity of the provinces. And this is something which we are in process of. And even today when I was in health ministry and day before, few days back when I was in CDC, so I asked them that I just want to share because the US have also the same type of government. There's states are, and then there's a federal government. So I think now things are improving, and most of the vertical programs like polio, routine immunization, TB, AIDS, and there's a linkage, and we have now, there's a more coordination as compared to the last year. So things are improving in that way, and I think we learn through our experiences. And this is a problem which, in the beginning, everybody faced in devolution. In case of, as far as polio and routine immunization is concerned, or you ask about the success story, and I think the best thing in Pakistan is that at least now we feel that we are on right direction. And everyone realizes. And we are focusing on, routine immunization. And a recent survey, PDH survey, which everybody was quoting, this was very alarming and eye-opener. And I personally feel that I always say that it is a collective shame for us and for all our partners also. And if you look at the slides which Dr. Bhutta showed, there are pockets where all the indicators are poor. And these are those areas where we have problem of law and order, insurgency, and in the previous last decade, we all know the challenges, the problem which we was facing, nobody in the world. I just want to share one example. There were 3 endemic countries in 2013. Nigeria, Afghanistan, and Pakistan as far as polio is concerned. Now, Nigeria has not reported even a single case from last 1 year. The reason being that the Boko Haram or the extremists, they are anti-states. They are not against the health of the people. Whereas the Taliban or the extremists which we were facing in Pakistan, they were not only against the states, they were also against the health education people. Then I must say that Shakil Afridi and many other episodes, people working undercover under international NGOs, they also affect our health services delivery. Because the force which we have, that is the lady health worker, the front line and the vaccinators. When people, the lack of trust between them and the household, that another adds to our challenges. And I think the success story is Prime Minister's Health Insurance, which is very new for us. And the second thing is that the budget increased in not only provincial government increased that budget, even the federal government. And when we talk about health budget, I mean, as Mr. Richard mentioned, we talk about only the health budget. There are many other initiatives taken by the governments which are not covered under the health ministry. They are under social protection. Then we have many other institutions. We have the largest program, best program, through which we are giving the financial transaction, cash transaction we are giving to the poorest of the poor. So now we have the survey, we have the data. And I think the way things are improving, definitely we have need continuity, but I think the indicators will improve in next 10 years.
Thank you.
Thank you.
Dr. Bhutta, would you like to weigh in? I think Dan was going to say
And
something.
another thing which I forgot to mention, that
please.
this 10-point agenda which we have, and this is a vision document under the instruction of Prime Minister which we made, and Dr. Bhutta was in it, and we are focusing on that. And definitely we need resources as well as political commitment to implement it, and we are working on that.
Now, I didn't have anything to say. I was deferring to Dr. Bhutta, the blue screen to my left.
Yes, Dr. Bhutta, we can hear you but not see you, so just speak if you would like to be heard.
Well, I'm cognizant of the bandwidth issues. I can turn the video on. I'm sitting in the evening in Karachi, having just got back from Islamabad. Let me start by thanking Minister Thakur for a fantastic presentation, which I think captures a lot of the emphasis that she herself in her leadership has placed on revitalizing, so to say, health stewardship in Pakistan. Pakistan is a difficult country. For many of you may know, it has huge challenges right now in terms of both access, insecurity, insurgency, and also largely a relic of a very hastily conducted devolution process that's only just being sorted out now. Now, I'm a great supporter of devolution, and I think there is great opportunity as we move forward for making health accountable in terms of provincial leadership, but also perhaps linking it to a stewardship process at a federal level, which is responsible for setting targets, goals, monitoring, and evaluation. I do want to make one comment because you asked about success stories, and I want to underscore as part of our recent analysis the very close nexus or link between periods of democracy, the democratization of public health in Pakistan, and how some of the best initiatives that we have seen to reach the poorest of the poor in Pakistan have been initiated by democratic governments and leaders. So starting off with the Lady Health Workers Program, which was started in the 90s because the Prime Minister of that time, Benazir Bhutto, was so taken by the whole issue after the Cairo conference that she came back and instituted it not only as an initiative, which was a pilot, but she nurtured it within the Prime Minister's Secretariat, the Income Support Program, and now within the current government, the initiation of health insurance, which I think is a fabulous opportunity to provide support against catastrophic coverage. So what I'm hoping is that some of these initiatives will now translate into impact at scale. I want to finish by just saying that, as the minister herself indicated, within the backbone of the polio program and the opportunities that it allows for better integration, there are success stories from some of the most difficult areas of Pakistan. We've been working with the government in the absolutely insecure corners of Karachi, areas where till very recently nobody could venture because of militancy and insurgency. And in the recent data that our team presented about 2 weeks ago in Karachi, we've now got close to around a 40 to 50% increase in the rates of fully immunized children and substantial reduction in terms of refusal rates for services. Just to underscore, if you create the right ambience of providing security, support, and confidence to civic society at large, people will rise and people will face any challenge. So thank you for the opportunity. I want to just underscore that in the government's own initiatives, civic society, the academia, the very vibrant group of individuals in Pakistan who are working with the public sector are absolutely ready to face this challenge. Thank you.
Okay, well, thank you. Good points all. I think we'll go to you all now. If you could wait until you're called on, until there's a microphone in front of you to pose your question, so that people listening via webcast can hear you, that would be great. And if you could give your name and affiliation, please pose a question. Don't make a statement if possible. So let's start in the back. Bill Milam.
Thanks, Michael. And I am Bill Milam. He's right about that. You spoke of success stories, not only within Pakistan, but without. And of course, there are several in South Asia. But the one that interests me most is the one that involves what used to be part of Pakistan, and that's Bangladesh. Now, the chart on the wall, the bar graph on the wall, shows Bangladesh at 2.3. We talked a lot about fertility. Maybe I should talk about that, begin with that. The fertility rate, which is quite, I think, quite important to this whole issue of health. And now, Bangladesh and Pakistan started as the same country, and in 1970, and I've done some work on this, they had the same fertility rate. And the fertility rate in Bangladesh came down quite quickly and has hovered around 1, 2, 2, 2, 3 for a long time. And we know Pakistan's has come down much more slowly and hovers up around 3. And I wondered if any of the panelists might draw upon these two models and figure out, and I wonder if there's been any work done, other than the little bit I did, about why Bangladesh has done so much better than Pakistan, not only in fertility, but if you look at most of the other social indicators you know, child mortality and all the rest, you'd find Bangladesh far ahead. This has, of course, been highlighted by Amartya Sen, the great economist, Indian economist. So I'd like the panel to sort of contemplate that, but maybe I can help by suggesting that there has been in Bangladesh a much more open attitude towards NGOs from the very beginning. And I think at the beginning of the existence of Bangladesh, there was a government determination to bring the fertility rate down, which I wonder if that's true in Pakistan. And that's my question, or that's my lot of questions.
That was a good one.
Yeah.
Please.
Let me, first of all, the role of international NGOs are very different in Bangladesh as compared to Pakistan. And we all are very much aware of it. The second thing is that from some previous years, I mean, again going back to the situation, the perception of Islam, especially in those areas where there was insurgency and some Taliban and some anti-state elements were there. So they created some, misconception about Islam. And another thing that the failure or we have not been able to achieve that growth rate is that our religious scholars were not on board. In Bangladesh, when they started this program, all the stakeholders were on board. And third thing is that they have their internal challenges, but they don't have any external interferences in Bangladesh. They have their, they have 2-party, 3-party systems. But I always say that it's easy to say and it's easy to compare Pakistan with any other country of the world. But the challenges which we are facing, especially in social sector, you can't compare it with any other country of the world. It is related. We need a multi-sectoral approach. Our education suffered. For all these indicators, if we want to improve, if we want to slow the growth rate, we need education. Our girls to be educated, especially the adolescents. I just want to give you example. I belong to a rural background. If there are 2 sisters, and one is educated in a city or working somewhere in an office, and the other one is in a village, so there's a difference, not only their approach toward the family, even the number of children is different. So this is the reason that there are many challenges, and now for the first time, we have taken all the religious scholars on board and from all sects, and we have constituted a task force at federal level, and we have to change the narrative according to our ground realities. Because if we talk about that two children are enough and we are going for family planning, maybe they'll say that this is not allowed in Islam. But if we'll go for maternal health and if we'll go for birth spacing, so I think, and we all realized that, we started in 60s or 70s in the beginning, and this program went very well. But in between, it was lost somewhere. And then all the governments, the dictators come, and then we go into this war against terror. So I think now we have realized, and as I mentioned in my presentation, that 3 provinces allocated more than 60 million rupees only for purchase of commodities. Previously, USAID supported us. So, there are many initiatives which we are taking, and if we want to strengthen the economy, if we want to look at it, so all these things are interrelated. So I think you rightly pointed out, and then we have another example of Iran also in our region. So we are sharing all these problems, and there's a G5 forum where we are sharing all these successes with Pakistan.
Okay, let's come down to the front. Just wait for the mic, Anwar. Thanks.
I'm Anwar Iqbal. I work for Pakistan's Dawn newspaper. You just spoke of the influence of religion. Can we say that we have too much religious influence in Pakistan? Reducing it would help. Is religion a problem now in Pakistan?
You're absolutely right. I think now things have changed. And especially I've noticed in polio that the refusal rate because of religion is less than 0.3%. Actually, the problem here is it's not only the religion, sometimes social taboos, sometimes inaccessibility to health facilities, then hard areas, then definitely poverty also added to all these problems. So I see as far as family planning is concerned, there was some issue in the past. And maybe the narrative which we built was not according to our ground realities. So I think, I feel that there are very small segment of the society. And now it is more limited to only extremists. I think it is no more an issue. And the best thing is to do that you must take all those people on board. Thank you.
Yes.
Yes, thank you. Michael, I'm Farhat Haq. I'm a Woodrow Wilson Fellow and a political scientist. So I think just 2 things that I would like to get some response on. I think the first one, religion definitely may be an issue, but I wonder how big of an issue it is. You're looking at Iran, and Iran presents itself as a pretty religious country, but there it's clear that the state was very focused on demographic issue and went very strongly to address that. And so there is a lot of noise that maybe some of the religious groups can make about some of these issues like polio or family planning, etc. But I'm just wondering how much of it is really the state neglect. And it is not something that's short term. It's been happening now for many decades now. And so compared to other countries, it's been my sense that social sector has really seriously suffered in Pakistan. That Pakistan is, as I think, Richard, you pointed out, one of the sixth from the bottom in some category that was mentioned. So how much of it has been really just a persistent state failure to address this issue, and this will haunt us in next 2 decades if we don't address this. This is a very scary picture we're looking at right now in terms of Pakistan's total fertility rate compared to our other South Asian neighbors.
Thank you.
Thank you. I think again coming to back the situation of Pakistan, discontinuity of the democratic governments, constant coups. If you look at the history of the Pakistan, it's more than half of 30 years they were dictators. The second thing is, I personally feel that the priority of social sector was, I mean, they were more focused on other things. And the second thing is that definitely disparity within the Pakistan. We have some area, when we talk about Pakistan, it's not only Lahore, Islamabad or Karachi. And if you look at the map, 1/3 of the map was red. And it is where our indicators become, I mean, low. Accessibility to the health facility, it is not there. Human resource is not there. So whenever there is a law and order situation, nobody will go there. In some areas of Fata and Balochistan, even the infrastructure for health are destroyed. So I know the picture is very haunting, but what I'm doing that now we have developed an agenda and we are working with the provincial governments. As far as the growth rate is concerned, that is an alarming issue. And I always say that we always talk about extremism, we always talk about suicide bombers, but the population bomb which we are facing is the serious one. So I think that, definitely it is a state responsibility. And health ministry was always, you can say, a donor-driven ministry. So the ownership of the government in some areas was there. We mostly spent our budget on cure side, on medicines. So rather nowadays we are focusing on preventions. And we are also focusing on public health and access to maternal and child health. And I think this 10-point agenda will help us. Because when we focus on the health of mother and on nutrition, I think the things will change. And this is the realization, not at federal level, but even at provincial level. And something coming out from Prime Minister's mouth, it means that there is a realization in present government.
Does anyone else on the panel want to weigh in before we go to the next questions? Okay. In the interest of time, I'm going to take a few questions at once. So we're going to take three. First, Anne, who has a mic, then the woman a few rows behind her, and then we're going to go over here. So, yes, Anne.
Yes, I'm Anne Sweetser. I'm a medical anthropologist. I've done quite a lot of work in development as well. I feel that the elephant in the room, as it were, is gender and the social issues and the nature of communication within a couple. The right of a woman to speak and articulate her needs, and the ability of a man to feel that his fundamental masculinity is not being challenged if the woman speaks up and expresses what she needs. I think in Bangladesh, BRAC and Grameen and the work that they did with women's groups, specifically to empower women without them becoming anti-religion, or inappropriate in their behavior somehow, was very, very significant in the drop of fertility in that country. And so I would just like you to comment on that. Although, in fact, you Honorable Minister, started responding to that in speaking about girls' education.
And while we're mulling over that, let's go a few rows back to take that question, yes.
I'm Insha. I'm from Pakistan, and I relocated here earlier this year, and I just want to say it's such a privilege to be in your presence, Minister Saiba. It was very reassuring to hear you talk about the 10-point agenda and the fact that you know exactly what is wrong, exactly what needs to be done, and the fact that resources are insufficient. My question was about, now that you are from within the government, are you also looking at the insufficient mechanisms for accountability? Is there something which is formally being done about it? Because as far as I know, and as far as the impression that I get from what you are saying, you know exactly what needs to be done. Gender, religion, policies, everything. You also know how insufficient resources are. Can you please shed some light on insufficient accountability mechanisms in the country? Because to me, that everything hinges on accountability, and the fact that why we as a nation state have become so comfortable with being inefficient. So something about that. In fact, if the representative from USAID, if you could also please kind of share your thoughts as a donor, the kind of mechanisms in terms of accountability and meeting committed targets. What happens about that?
Okay, and just one more question, as if that's not enough to think about. Question from Sandeep right here.
I'm Sandeep Pathala. I'm the Senior Program Associate with the Maternal Health Initiative and Environmental Change and Security program that Michael referenced. And I have to just personally say that this collaboration, I am extremely jealous that you're moderating and not I. Although you're doing a better job than I would have.
I don't know about that. Thank you.
So my question, and some of it has been addressed already, you talked a bit about efforts around data collection in particular areas of conflict within Pakistan. You talked a bit about infrastructure within those areas, as well as human resources and impact on indicators. But I'm wondering if you could talk a bit more about success stories around quality of care also. And I think that also feeds into infrastructure and human resources. But I do know if we look in the South Asian region in particular, our programs have done some work on the ground, in particular in South Asia. There's a lot of discussion about marginalized communities and quality of care issues. So if you could expand on that, that'd be great.
Now, coming back to Insha's question, I think as far as myself is concerned, I believe in ruthless accountability. And you know, this is a problem, it's not only in Pakistan, but in most of South Asian and third world countries. Now, the problem with this is that the system, especially in public sector, the people who are working in these institutions, they get so used to it. And for me, it's not only financial corruption. If you are not sincere to your work, and if you are not delivering anything, that is another corruption which you are doing. And these institutions and the present government, and I think as far as accountability is concerned, now we have been given the goals which we have to submit it to the Prime Minister office through Planning Division, that where we will be in June 2016. And everybody, I mean, you know, when as a Minister of Health, Prime Minister gave me that these are your, initiative of the government, and you will be accountable of what you have been doing. So this is, and another thing which I want to say is that now there's awareness in Pakistan also. And at least through media, through civil society, and through, the world is changing. So we can't be isolated, and we keep, and you as a Pakistani are saying that we are as an inefficient nation. So I think now the glass is full. Now we can't afford even a drop of water. And I think that this accountability is done. We have many institutions also, but there's a mechanism also within the government. As far as donors' money is concerned, I think most of the donors, they have their own mechanism and impression that the countries are, and we are having those share of it. So they don't give us cash. They always help us in kind, in capacity building, in technical support, in providing us equipment. And I think I totally agree that through accountability and close monitoring only, you can make difference in a country like Pakistan. And this is the reason that I am focusing on the system strengthening. So when I was in CDC, when I was in the State Department, and even through our partners, I've asked WHO to establish, I've asked USAID, and now we are creating a dashboard at federal level through which we can monitor the provinces, even through those districts. So we are developing those mechanisms, and that we can only do through technology, not through human resource and the person who are already sitting there and who are good for nothing. So I personally feel that these are something on which we are working, and I think we have to learn from others' experiences also. Thank you.
Well, from as far as the three questions that were asked are concerned, they're actually connected from a certain perspective, which were about the role of gender, accountability, and the quality of care that's provided. One thing that I didn't mention earlier is that in the 5 different sectors that USAID is partnered with the government of Pakistan on, energy, economic development, it's education, et cetera, in public health, there are 2 cross-cutting themes across every sector. And it is both attention to gender within each sector and good governance. And so then that's basic policy that's mandated from the U.S. government. So as far as gender is concerned, we make sure to factor that into the programs that we support for education, for economic development, so that women are included as well. And that also goes as far as our involvement with public health, certainly for women and girls. And then separately, for both accountability and quality of care, in a way, these are 2 sides of the same coin. As far as accountability is concerned from USAID's perspective, we're absolutely mandated to track the effectiveness of the programs that we support, and that the money that is spent that comes from U.S. taxpayers goes to the best possible outcomes and is carefully tracked from one step to the next so that everything winds up where it should go and winds up being spent the best possible way so that the quality of what is given is maintained to a high standard. That's something of a simple answer, but it has the benefit of being true.
Okay, we have time for two more quick questions, very quick questions, and we'll take them consecutively. So the first, the woman in the, I think it's a black shirt right over there, and then the second one, Sarah, you had your hand up over here on this side.
Thank you. This was a wonderful panel. I am actually Pakistani American myself. I'm my name is Umbareen Shafi, and I'm the executive director of the Pakistan Literacy Fund. So we run over 230 schools in Pakistan. So the issues that you've raised about gender and education, economic access, all of those things are very important to me. But one thing that was only briefly touched on was climate change and the role of the environment in stabilizing the infrastructure and affecting, you mentioned that it's a multi-sectoral approach, and you mentioned that all of these things are interrelated. So I'm curious to know, there's an amendment to the Montreal Protocol that's on the table right now that 95 countries have currently submitted proposals for. And it's to eliminate HFCs, which is a chemical used in air conditioning and refrigerants. So it's an air pollutant, and it can halt the effects of climate change by almost 50%. And there are only 3 countries that are holdouts, and Pakistan, Saudi Arabia, and Kuwait are the 3. So I guess I'm curious to know, why wouldn't Pakistan want to make more efforts to, further the needle on climate change and further the cause on, ending the environmental degradation in the country when that so deeply affects infrastructure? I mean, if the children are not healthy, they're not going to go to school, they're not going to be able to perform very well. So I'm just wondering, how and why that issue is not as important to Pakistan as it maybe should be.
Okay, thanks. Yes, sir?
Phil Schrafer, a retired international healthcare worker who worked in reproductive health in Central Asia. I think my question's for the minister primarily. Breastfeeding, I think I heard 30% was the level of breastfeeding. I wonder what success stories there are to have improved this, because obviously breastfeeding affects the bonding, nutrition, and spacing between births. So comment on that, I appreciate it.
I think that climate change is quite important for Pakistan, and Pakistan is a country which is very prone to natural disaster. Every second year we are facing floods, there were earthquakes, and we are focusing on that. And the reason being that I know one of my cousin was former DG Met, that Pakistan is also purchasing many equipment to enhance the capacity of our meteorological department. Then we are also strengthening our Ministry of Climate Change, and we are developing linkages between the National Disaster Management Institution and Aviation Department. Then we have their linkages at the provincial level also. And I think climate change is a phenomena which nobody can deny. Why Pakistan have not signed it, that is not in my knowledge, and maybe some reasons. Doctor, if you can answer. Yeah. So I think I've been told that in the recent discussion with the Prime Minister of Pakistan and with the State Department, they have agreed. Because, most of the time there are some issues, sensitive things which are included in those, MOUs which we are going to sign. So once they are clear, so I think we are focusing on that. And our minister and the ministry, they are working quite hard in that. Now, coming to the breastfeed, I totally agree that the figures of breastfeedings are static from last 20 years. And previously, it was because of those women who are working there, because we don't have that much facilities of healthcare and daycare centers there. But unfortunately, now the number is also decreasing in rural areas also. And recently, on the Breastfeeding Day, we have an institution in Islamabad. So we developed a presentation, and we launched an awareness campaign for all the mothers, that how you can prevent your children through breastfeeding for so many diseases. And it is a natural, phenomena for birth spacing also, and also to develop immunity among the children. So we develop a linkage between the gynecologist and the child specialist, especially in public hospitals. And I think this is an area, excuse me, on which we are working. And I think another thing is that the diet of mother, a malnourished mother, I think after 1 month or maybe 2 months, they feel that they don't have enough milk to feed. So we have to change the mindset also. And I think we are working on that. And that is another area which is of prime concern to us. Thank you. Another thing which the question you asked, that what government is doing for the marginalized population. This recent Prime Minister Health Insurance Scheme, then the facility in all public hospital, I was just discussing with the Deputy Secretary of Health, that in Pakistan, there's a free treatment for everybody in public sector hospitals, whether it's a delivery case or a bypass. So, this is the reason that why there's so much pressure. So now this insurance card is for the poorest of the poor. A person whose daily income is less than $2, they are going to be the beneficiary of this program. So there are many other initiatives from provincial governments also. We have an institution, Baitul Mal, then we have a Zakat fund through which these people we help, and they are getting the health facilities. Thank you.
Well, thanks. Any of our other panelists would like to make a 20-second final statement?
I'd like to defer to my colleague who hasn't had the chance to speak.
I'd just like to say I wish our congressmen were as focused and articulate as Minister Tarar is. I think we'd have a better government. So thank you so much for...
So I think the complaint for the government is same all over the world.
Okay, well, yeah, thank you very much. And thanks especially to Minister Tarar. Really appreciate you.
Mr. Richard, the world is so globalized that anything which I say here, and if you feel it's not true, and I'm always very blunt and open. And I feel that whatever we are doing, we are focused, the present government, we know what we are doing, and I hope you will feel the difference. Thank you.
Thank you. Thanks again.